I got some grievances to air about how some textbooks and protocols teach paramedics and new paramedics and students how to give Narcan. Naloxone is not something that should be given empirically and willy-nilly. It's given for a really specific cause. Let me see if I can convince you. My name is Angry Bill. This is Prehospital Wisdom. We understand that medicine's medicine wherever you go, but pre-hospital providers like EMTs and paramedics have special skills, knowledge, and experience that makes their job a little bit special. Help me raise the bar here a little bit. So Narcan, what is your threshold for giving naloxone to a patient? As a professional paramedic, I'm not talking in this case about civilian Narcan. If you have a loved one at risk that you find unconscious and have Narcan available, give it. Don't overthink it, don't over-question it, just roll with that. As a professional, as a paramedic, it's something I want to talk about. So for example, look at this textbook excerpt here. This has a nice little flow chart, starts with suspected opioid poisoning, and then asks you, is the patient breathing normally? I have a problem with this right off the bat. It's not whether or not the patient's breathing normally. What if they're tachypnic? What if they're gasping and crying? It's not normal breathing, but it's not warranting Narcan either. What we're looking for is hypoventilation. But in any case, we'll leave it alone. In this case, it says, is the patient breathing normally? And we'll go to yes. Let's say they are breathing normally. They're just sitting there minding their own business, breathing normally. What's next? Prevent deterioration. Tap and shout, open the airway, consider naloxone, and transport. Why would I even consider naloxone if they're breathing normally? Let me tell you a story. Once I went to a park and ride type area. The transit police had found a undomiciled individual overdosing, or at least using, in a porta-john. They got him out of the porta-john. He's awake, he's upright, he's walking around, but he is high. He just had a belt around his arm and a needle in it and was sleeping in the porta-john. Right now he's up and walking and fairly normal right now, right? Well, new Bill, at that time of my career, decided Narcan. In this case, here's the problem. It wasn't heroin that he was shooting. It was heroin mixed with either methamphetamine or cocaine. And so right now he's in a balance. The sympathomimetic effects of whatever it was, the cocaine or the meth, is balanced out by the kind of narcotic effects of the opioid that he was taking. That's balanced. Now, if I take away the effect of the opioids, and all I'm left with is a fight. I'm left with cocaine with no brakes, or methamphetamine with no brakes, and all of it for no reason. Do you want to know what's embarrassing? Is chasing Narcan with some Versed or droperidol. The patient was mellow, the patient was going along. I had no need to ruin his high. So I personally think we should only be giving Narcan to patients with hypoventilation, and especially when I can't bag them up out of that, right? I'm even down with it being inconvenient to bag them. That's fine. Step one is always to open the airway, bag the patient up, breathe for them. If at that point they're hypoventilating, then Narcan is warranted. Without having that reason, all I'm doing is ruining a high for no reason. It's not my job to ruin highs. Here's another time when Narcan should never be used, and it even comes from that same flowchart from a textbook. Look over here, is the person breathing normally? No. And then follow that, does the patient have a pulse? Also no. You start CPR using AED and consider naloxone again. I wonder if one of the H's and T's is hyponaloxonated. Is that what's going on? Why would I give Narcan to a cardiac arrest? Squeeze the BVM better, faster, more deeply, whatever you got to do to increase the minute volume, that's how you increase the minute volume. Cardiac arrest is not caused by opioid overdose. Cardiac arrest is caused by apnea or hypoventilation. In an intubated patient, I should never be giving Narcan. I understand there's never and never and never and always. But think about this. One of the ways that I sedate an intubated patient, besides the general sedation, it also requires analgesia. And what's my favorite analgesia to give to an intubated patient is fentanyl. Why would you give them Narcan and take that ability away from those providers? Narcan's not an empiric medication. Narcan shouldn't be treated that way. Narcan's not for undifferentiated cardiac arrest. Narcan's not for undifferentiated altered mentation or highs, or even when people are known opioid abusers. That's not why we're giving it. We're not precipitating withdrawal. We're not here to precipitate fights. We're not here to complicate the management of intubated patients. Narcan is not as willy-nilly as many places, many protocols, many textbooks seem to make it. What do you think? Do you agree with this? Should we be giving Narcan to everyone? Just giving out Narcan willy-nilly, or should we be directing it to specific hypoventilating patients? Not even abnormally breathing patients. There's a lot of reasons to breathe abnormally. And hypoventilation due to an opiate overdose is my personal threshold. So here I'm going to take a minute, remind you, I don't sign your paychecks, I don't hire, I don't fire, I'm not your boss, I don't read your PCRs, so good luck to you wherever you work. Hopefully you work in a place that uses their brains a little bit and agrees with me. So, I'm Angry Bill for Pre-Hospital Wisdom. Hit like if you like this, subscribe if you really like it, make sure and share it with someone. Until next time, go easy on the Narcan.